Okay, hopefully you can see my screen now. Please, Sunny, please tell me if you can't see that, but it should be okay. Good. Well, Mingalabar to everybody who's tuned into this webinar. It's a great pleasure for me to engage with our medical colleagues in Myanmar, and it's nice for me to see some people I know from the ENT community in Myanmar also tuning into to this. So my name is Robin Youngs. You can see me here in this picture operating in the Eye and Ear Hospital in Mandalay a few years ago. I'm an ear, nose and throat surgeon from the east of England. I'm also an honorary associate professor at the London School of Hygiene and Tropical Medicine. I've known Sunny Yong for probably long time. I think maybe 30, 40 years even. So we've been friends for a long time. And for many years, we collaborated on a teaching attachment or friendships with our colleagues in Myanmar. This started in 2002, and we visited on many occasions. Okay, just trying to get my slide working. Let's do it like this. So some of you will recognize on the right-hand side here the late Professor Miu Min, who was instrumental in starting our collaboration. He's sitting here with my good friend, Professor Nick Stafford, who with me and also with my friend Kate Evans organized educational links with Myanmar over a 20-year period. And during that time, we made many good friends, and you can see a lot of them here. This was taken in the ENT hospital in Yangon. And if anybody, if any of them are tuning into this, then we send them our good wishes. But also, if people are in contact with many of our friends who we can see here, please pass on our wishes and also emphasize that we haven't forgotten them in any way whatsoever. So as I mentioned, we operated and taught in the ENT hospital in Yangon and also the ENT and Eye hospital in Mandalay. And you can see here I'm testing the hearing of a patient who had a stapedectomy operation the day before in order to treat hearing loss. We did a lot of educational things. This particular picture shows a temporal bone surgery course that we jointly organized with the Thai Rural Ear, Nose and Throat Foundation, which was run by a very inspirational man called Sal Lekagal, whom some of you may be aware of. In more recent years, I was involved in an NGO that had links to help deaf children in Myanmar, and we supported colleagues in the schools for the deaf in Yangon and Mandalay. This particular picture is taken in the school for the deaf in Mandalay. And there we tested children's hearing and also fitted a large number of hearing aids. In addition, we trained the teachers of the deaf to look after the hearing aids and in deaf education. And again, we send our best wishes to all of our friends and colleagues in both of these institutions. So what I'm mainly going to speak about today is otitis media. But we also have time at the end of the talk for you to ask me any questions about anything in otology that you would like to know. I think we're going to do other ENT talks, mainly on rhinology and possibly head and neck surgery. So This evening, we'll concentrate mainly on the ear. So what is otitis media? Well, otitis means ear, it's Latin for the ear, and media means middle. So it's inflammation of the middle ear. And if we look at a diagram of the ear, we can explain the anatomy, because the anatomy is very important in understanding all ear disease. So we can see on the left-hand side of the slide, the external auditory canal. What happens with sound? You can imagine a sound wave coming down the ear canal, shaped like a sine wave, and then the sound hits the tympanic membrane, which is in dark green. The tympanic membrane or eardrum then vibrates, and that vibration is transmitted through three little bones of hearing: the malleus, the incus, and the stapes. The stapes is attached to the middle ear, particularly this thing that looks like a snail called the cochlea. And in the cochlea, energy from sound waves is converted into electrical energy, and that passes up the cochlear nerve to the part of the brain that deals with the conscious appreciation of sound. Now, in terms of otitis media, the important and anatomical fact is that the middle ear, which you can see in red in this picture, is connected to the upper respiratory tract by the eustachian tube. So the end of the eustachian tube is in the nasopharynx. So that means all types of germs and bacteria can pass up the eustachian tube into the middle part of the ear. And it's that gives rise to the possibility of otitis media. The other parts of the ear that are important, we can see here the semicircular canals and the vestibular nerve. And I'm sure that you're all aware that these are important in the control of balance. So diseases of the semicircular canals give rise to the symptom of vertigo or imbalance. Vertigo means a sensation of movement in the absence of movement itself. The most common form of otitis media is acute otitis media. And that's very common in children. It usually complicates an upper respiratory tract infection. It's more common in temperate climates, so I expect it's more common in places like the United Kingdom, where we have cold winters, but it does occur all over the world. And the picture you can see on the left-hand side is a picture of an eardrum, and it's bulging. And what often happens in acute otitis media is that the eardrum perforates, and you get discharge coming from the ear canal. It then heals up and normally gets better. Now, treatment of acute otitis media, most of these cases resolve by themselves and don't need any treatment. For children that have recurrent acute otitis media, or cases that don't settle down after 2 to 3 days, then it may well be worth treating with a short course of broad spectrum antibiotics. Now, there's another variant called otitis media with effusion, and this particularly occurs in children as well, and it causes a mild conductive hearing loss. So it can cause educational problems. Again, it's probably much more common in parts of the world like where I live, in temperate climates, and it's much more common in the winter months. Usually it doesn't need treatment, but occasionally it needs to be treated either with a hearing aid or grommet insertion. Now, the other thing with otitis media with effusion that's important, remember what we're talking about is fluid behind the tympanic membrane, is that it can occur in adults. If it occurs in adults, it often means there's obstruction of the eustachian tube. And in adults, that can be a sign of nasopharyngeal carcinoma. And nasopharyngeal carcinoma is rare in the UK, but is very common in Southeast Asia for various reasons, partly due to the fact that it's linked with Epstein-Barr virus infection and partly genetic reasons. But it is a very common malignancy in parts of Southeast Asia, and our ENT colleagues in Myanmar would be very accustomed to seeing people with nasopharyngeal carcinoma. So it's very important to keep that in mind in adults. So what we're largely going to talk about is chronic otitis media. And you can see this picture shows the main symptom of chronic otitis media, which is discharge from the ear. So to have chronic otitis media, you need a perforation of the tympanic membrane, and that causes continuous or intermittent discharge. So these pictures show what one would see looking down an otoscope in chronic otitis media. So on the left-hand side, there's a perforation of the tympanic membrane. This particular one is dry, so there's no infection there, but what you can see is the structures of the middle ear through the hole in the tympanic membrane. On the right-hand side, you can see a perforation again, but the difference in this particular case is that there's infection, which means that there's discharge coming out of the ear. Now, there is a variant of chronic otitis media which is potentially much more serious, and this is something called cholesteatoma. Cholesteatoma happens when you have a perforation of the tympanic membrane and it becomes full up with dead skin, which is the whitish structure that you can see in this picture. And cholesteatoma is associated with a type of inflammation that can erode and destroy adjacent structures. So it's potentially much more serious. So this particular case is cholesteatoma. This is a little girl who I treated in Nepal, and she's got disease that has eroded through the skin behind her ear. And you can see this is here on the operating table. And again, you can see it's very nasty appearance. And the fact that this disease has eroded through the skin means it's much more likely to do damage inside as well. Now, there are some important structures in the ear. One is the facial nerve. So cholesteatoma can erode through the facial nerve, causing a facial nerve paralysis. And if that happens, it's usually permanent. Now, you will know this lady comes from Myanmar because you can see the Tanaka that she's got on her face, but also you can see her ear looks very nasty indeed. And she had a complete facial paralysis on the left-hand side, but she also had this fistula with a huge cholesteatoma leaking behind her ear. A really nasty thing, and she'd been unable to get treatment for this for many years. And she was treated when we visited Yangon on one occasion. A really nasty case of chronic otitis media. A cholesteatoma can also be fatal because it has the potential to spread to the brain. This MRI scan on the right-hand side shows, oops, hang on. On the right-hand side shows a brain abscess in the cerebellum caused by chronic otitis media. On the left-hand side, you can see a very sad case of a boy we treated in Nepal who had a discharging fistula behind his ear and was moribund, almost certainly due to an intracranial complication. We treated him with antibiotics, but he started vomiting, possibly due to a brain abscess, and his parents took him away. Very sad case. Now, this is a little boy who we treated at the ENT and Eye Hospital in Mandalay. And I want you just to take a few moments to look at the picture and see if there's anything that you can particularly notice. Now, obviously, he's having his ear looked at by an otoscope, and it's worth actually talking a bit at this stage about examining the ear. The person who's doing this examining is holding the otoscope in his right hand, and with his left hand, he's pulling the ear backwards and upwards. So this is the proper way of examining somebody's ear with an otoscope, because it has the effect of straightening the ear canal. So that is a good otoscopic technique. But I'm sure that you've noticed here that there's two scars. One here and one here. And what's happened with this little boy is that he's had a discharging ear for a long time, but also he's presented with a brain abscess. So he's had that drained by neurosurgeons, and he's presented with an abscess behind his ear. He had a very large cholesteatoma, and he never had treatment for that per se. He had treatment for the complications of cholesteatoma, but not the cholesteatoma itself. So we operated on him when we were in Mandalay. This is him just before the operation. This is him undergoing surgery. It's one of the cases that I operated on myself as a way of teaching our ENT colleagues mastoid surgery. It's quite a complex operation. It takes about 3 hours to do, involves using drills and microscopes. And this is him recovering after his operation. I hope that as a result of his operation, he made a good recovery, and that he hasn't had any more complications of cholesteatoma. So what are the chances of somebody with a discharging ear getting intracranial complications? Well, there is a study undertaken by two people called Desmond Nunes and George Browning many years ago that calculated that the risk of somebody getting a brain abscess with a discharging ear was 1 in 200 over 30 years, with an annual risk of 1 in 10,000. So it's not a big risk, but there again, it's not a negligible one. So it is something that's very important to be aware of. Now, how common is chronic otitis media? Well, this is shown in this graph, and this map. The map of the world has shown 3 areas of different prevalence. So those of low prevalence tend to be high-income countries, so North America and Europe, Japan. Those of intermediate prevalence, so that's up to 1 to 4%, tend to be areas like South America, Southeast Asia, the Mediterranean countries, South Africa, but also you can see Southeast Asia, although I suspect that in Myanmar, the prevalence is higher than 1 to 4%. And areas of high prevalence are Sub-Saharan Africa, South Asia. And it may interest you that the place in the world with the very highest prevalence of chronic otitis media is actually a high-income country, and that's Australia. So the indigenous population of Australia, the Aboriginal population, has a prevalence of up to 50% of chronic otitis media. But I think in Myanmar, the prevalence of chronic otitis media is probably going to be about between 5 and 8%. So it's probably between about one in every 12 to 20 people will have discharging ears. So it's a very common thing. The reason it's common in particular countries is that it's very associated with adverse social determinants of health. So poverty, poor environment, lack of education, and poor nutrition. So those countries like Sub-Saharan Africa and South Asia, and I'm sure many parts of Myanmar will have high prevalence of chronic otitis media. So these are statistics from the World Health Organization. 4.68 million disability-adjusted life years, and over 20,000 people dying every year due to complications of otitis media. That's almost certainly an underestimate. And the most recent statistics show that deafness as a whole is the fourth most important disability of all health conditions. So in terms of the impact. So for example, it's more important and prevalent than diabetes, blindness, asthma. It's an incredibly common disability. What I want to do now is just to examine what it's like to live with chronic otitis media, because people who don't have discharging ears don't really have an appreciation of what it's like. So people with hearing loss have problems. So if you're a child with hearing loss, you may not be able to develop normal speech and language. If you're an adult, you may not get a decent job. And if you do get a job, it probably won't be paying that much. If you're elderly with deafness, you may be socially isolated. On top of that, people with chronic otitis media have to cope with discharge from the ear, which is a symptom that gives rise to huge stigmatization. For many years, as well as working in Myanmar, I've worked with an NGO in Nepal, the Britain-Nepal Otology Service, and we've run a community ear care program since 2000. And I've been involved in a bit of research to look at the quality of life of people who suffer with chronic otitis media. So this study used something called the HUDAS instrument. Now, HUDAS stands for World Health Organization Disability Assessment Score. And with this particular quality of life instrument, it enables us to compare different disabilities. So these are the different domains of the World Health Organization Disability Assessment Score. So you've got cognition, communication and thinking, mobility, self-care, getting along, life activities, and participation. And one of these in our study scored very highly in people with chronic otitis media. So maybe just take a few moments to consider those and see what particular domain you think would be highly scoring in otitis media. So it's this one, participation in community activities and personal dignity. Very high scores. And this graph shows that the high score, the more severe the hearing loss, the higher the score was, which is perhaps not surprising. Now, we did another study which involves something called qualitative analysis, which is where we ask people with chronic otitis media to present their stories in a sort of narrative way. It doesn't mean that you end up with a number, but you end up with an understanding of what life is like for them. So there are a number of effects of chronic otitis media. So remember, these are people with hearing loss and discharge from the ear. So the discharge meant that they might be teased and bullied. They might worry about others would behave towards them. There was frustration. And also there were some positive social interactions in that they often relied on other people. So those were social effects, but there's also emotional effects. They felt sad. They felt they might be a burden to others. And they felt afraid. So they felt afraid of the possibility of complications, and also afraid of maybe having to have an operation and maybe couldn't afford it, or were worried about complications of surgery. There's functional impact. So people with hearing loss would have trouble at school and at work and in social interactions, and many of them would have to use coping mechanisms. So this is just two examples, and I'll read them out to you. So one lady, 20 years old, if I put cotton wool in my ear, then people will know there is a problem. If I have discharge, they will think I am dirty and not sit with me. This is a particular problem with females who have chronic otitis media. The next one from a 38-year-old man, I've been very sad from childhood until now. In childhood, my friends used to laugh at me. I used to think, why are they laughing at me? So how do we prevent chronic otitis media? Well, the main thing is to address poverty. That's going to be a really big way of preventing it. Public health measures, particularly vaccination against measles, mumps, rubella, meningitis, is also going to prevent a huge number of cases. Awareness is very important as well, because particularly in remote communities, people are often not aware of ear disease and the fact that you can get treatment for it. There may be a lot of sort of old wives' tales, and they may go and see local healers who give them wrong advice. So awareness campaigns are very important. And I know that in Myanmar, many of my ENT colleagues have been involved in awareness campaigns to educate the population on the importance of ear disease. Now, the treatment can be medical, surgical, and also rehabilitation. So otitis media, when it's associated with a discharging ear, is an infection. So it's logical to think that you might want to treat it with antibiotics. The important thing is that these antibiotics have to be given locally, so they basically have to be ear drops, because antibiotics by mouth aren't going to reach high enough concentrations in the ear to be effective. Now, the type of antibiotics we use, this is eardrops made out of ciprofloxacin. These are quite commonly used. Also, aminoglycoside eardrops, such as neomycin and gentamicin, can be used, but you have to be very careful because there is the possibility of ototoxicity. So, gentamicin and neomycin potentially cause damage to the inner ear. So it's important that if you're using them for a discharging ear, that you only use them for an ear that's actively discharging, and also for less than 2 weeks at a time. So that's very important. But the definitive treatment of chronic otitis media is surgical. So these people have to have operations. The repair of a perforation is called a tympanoplasty. You can see this man is undergoing a tympanoplasty. He's actually awake, so he's having the operation under a local anesthesia, which is certainly very possible. And it means that these operations can be done without the need for a general anesthetic. They have about a 90% success rate, but it's important to realize that the results are not apparent until about 3 months afterwards. This makes it completely different to, say, surgery for cataracts, in which patients can see straight away after surgery. Cholesteatoba operations are a little bit longer, and they entail a mastoidectomy. They had to be done under general anesthesia, so that's very important. And hearing aids are important as well. Rehabilitation for people with hearing loss is very useful. The problem is with people who have discharging ears, they find it difficult to wear hearing aids. I'll talk a little bit about deafness in children. This boy in Mandalay is having his hearing tested. Severe deafness in children, the prevalence of that is 1 in 1,000 children. So 1 in 1,000 children will have profound or total deafness. So by that logic, there are going to be many thousands of children in Myanmar who have problems with severe hearing loss. So these particular children are in the School for the Deaf in Mandalay, as I've mentioned before. And the important thing is that the majority of deafness in children is preventable. So 60% of hearing loss in children is preventable, mainly, as I mentioned before, due to immunization against these things: mumps, rubella, measles, and meningitis. So immunization is important. Good perinatal care is also very important, and also the avoidance of ototoxic medications, particularly aminoglycosides. The majority, this 40%, are genetic and is non-preventable, although some of these genetic causes are caused by consanguineous marriages, so cousin-to-cousin marriages. So they are potentially preventable in that way by avoiding them. Now, otitis externa would be very common in Myanmar, infection of the external auditory canal. And you can see this particular picture shows a narrow ear canal with discharge. This next one shows a swollen ear canal. Would be very painful, difficult to get eardrops in. This one, I'm sure you'll recognize, shows fungus. So fungal otitis externa, you can see these fungal spores here. Very common, particularly if people have used antibiotic eardrops more than they should have done. Various treatments for otitis externa. the main thing is to try and clear the discharge out. So you can use gentle syringing. If you're in secondary care in an ENT department, you can clean with a microscope. Might be very painful, so they may need painkillers, ear drops, and possibly ear wicks. Now, if you want to learn more about particularly otitis externa, there is a website called the Global OHNS. This is a collaboration of ENT surgeons and audiologists around the world, and they've got together to produce global ENT guidelines. And I'm just going to try and link to this, but I'm not sure if I'll be able to. Let me just no, maybe I'll do that after we finish. I'll link to this website because the guidelines for otitis externa. Maybe we'll try this. No, it's not going to work, unfortunately. The guidelines for otitis externa have been written by one of our Myanmar colleagues, Dr. Maytu Thor, who works in Mandalay. I'll try and link to that after we've finished. So that's about all I want to say for the moment, but we'll have a discussion afterwards, and I'll be happy to answer any questions that you have. And once again, I send all my good wishes to all of our colleagues and friends in Myanmar, and I look forward to the day when I can return and renew our friendships in person. Okay, thank you very much. So maybe I'll stop the screen sharing. Yeah, okay.
Thank you very much, Robin, for an extensive talk about otitis media and its complications. We have a few questions in the chat box. I don't know, maybe we'll...
Yep, I'll have a look.
Externa, as we've just touched on otitis externa.
Yep.
We could go into the treatment a little bit more, because I'm sure there's a few questions on, yes, on what drops to use.
Yeah, absolutely.
Thank you.
Yep. So otitis externa is common. So it's an infection of the external auditory canal, and it's more common in hot climates. It can be precipitated by people putting things into their ear, and it presents with a painful swollen ear canal. So the treatment is, if it's very painful, to give analgesics, but also to give local, usually antibiotics. And the antibiotic ear drops that we tend to use are either aminoglycosides, so that's gentamicin and neomycin. There's another one called famotidine. So you may know them by trade names. Otosporin is a very common trade name that has neomycin in. And the other ear drops that are used very frequently now are quinolones, so ciprofloxacin and ofloxacin. The problem with using quinolones, they're very effective, but there is a theoretical risk of developing antibiotic resistance. The other thing with otitis externa is the ear canal may become very swollen. And so you may need to put what we call a wick in the ear. Now, a wick can be made out of ribbon gauze, and that can be impregnated with antibiotics and maybe steroids. So maybe on a wick, you could put some antibiotic and steroid ointment, and that would usually be, again, something like neomycin and maybe a steroid as well, hydrocortisone, and then leave that for a couple of days, and that would reduce the swelling in the ear canal, so that then afterwards you could use ear drops. There's also fungal otitis externa, and that's very, very difficult to treat, because it tends to grumble on and can be very, very difficult. Now, with fungal otitis externa, you probably need to make a diagnosis first. So if you have facilities to do an ear swab, do that and prove that it is fungal. But if it's if you haven't proven that, then you can use antifungal ear drops such as clotrimazole. That's the most common drop to use, and you normally you need to use that for about 2 weeks at a time. So that's otitis externa. So I'm looking in the chat box now. How to manage excessive nose bleeding in non-hospitalized setting? Well, I think you're getting another webinar on rhinology in a few weeks' time, but I'll give you managing excessive nose bleeding can be difficult. The important thing is to initially you pinch the nose. So if I do it on myself, the important thing is to pinch it at the soft part and lean forward, because most bleeding comes from the anterior part of the nose. But then you may need, if it really bleeds a lot, to put some type of dressing in the nose. And you can use swabs and tissue paper, but if it really bleeds a lot, then that patient is probably going to try and need to find some treatment by an ENT doctor. Okay, I can see a couple of questions about tinnitus. Now, tinnitus is, the thing to do with tinnitus is that it's a symptom, not a disease itself. So tinnitus, which is usually ringing in the ear or buzzing, can occur in any type of ear disease. It can be very annoying. The treatment is usually to treat the ear disease itself, but it often happens in people with sensory neural hearing loss, and can be difficult. So, for example, people with sensory neural hearing loss, then ideally you might want to treat them with a hearing aid if that was available. Now, I can see from the particular question about unilateral tinnitus with suspected eustachian tube obstruction with vasomotor rhinitis and right side of tongue, especially posterior part numbness and tasteless. I mean, I think there's a lot of symptoms there that would need evaluation. So I think that type of patient would probably need to be seen by an ENT doctor, because particularly if you've got numbness of the right side of the tongue, it may mean you've got something going on in the pharynx, maybe a malignant disease of some type. So I think a proper assessment would be important then. So I think I see gentamicin versus ciprofloxacin in otitis media and ototoxicity. So we discussed that a little bit. So ciprofloxacin isn't ototoxic, but gentamicin is. But you can use gentamicin in otitis media and discharging ears, but you have to use it with safeguards. So our association, ENT UK, have said that you have to use it in an actively discharging ear and for less than 2 weeks at a time. And if you do that, then the chances of ototoxicity are pretty small. Now, any role of povidone eardrop? Well, that's really interesting, because the answer is yes. I've been involved in some work with the London School of Hygiene and Tropical Medicine. And I know that there are doctors in some parts of the world, there's particularly a Korean doctor who works in Fiji, who is a big advocate of using povidone eardrops. So that's povidone is iodine eardrops, and to use that in the ear. And that's certainly, if antibiotics are not available, then using iodine eardrops is possible. The important thing is that if you're using iodine, is it must be in a water-based solution. So it must be an aqueous solution, because alcohol is potentially ototoxic. So as long as you use the usual preparation is betadine, as long as you use povidone or betadine in a water-based solution, then that's okay. What you shouldn't use is an alcoholic solution or a soapy solution. So the soapy iodine is used for washing hands and surgeon scrubbing. You shouldn't put that in the ear. Hydrogen peroxide in the ear. So we haven't really covered wax yet. So wax in the ear is a very common thing. And the first thing to say is the wax has a function in the ear. It's antimicrobial, so it is a normal thing. And what usually happens is the wax migrates out of the ear and is not normally a problem. Particularly in people in Asia, they tend to have a genetic thing, is have to have wider ear canals. So wax is less of a problem in Asia than it would be in, say, in Europe or North America. But if you do get problems with wax accumulation, then trying to soften it and using hydrogen peroxide in the ear is a possible way of doing that. But you can also use other things. Sodium bicarbonate eardrops is a very common way of doing it. Excuse me, I just had a drink of water. And then you might need to syringe the ear as well. So that's a possibility too. So what ENT book is good for reading? Well, that's an interesting thing. There are lots of ENT books around. When I was working with Professor Stafford, we did a little ENT book called Colour Guide in ENT. I'm not sure if that's still around, but what I would recommend is a book that's got a lot of pictures in, because that will help you understand the clinical signs of ENT problems. So any role of oral antibiotics in otitis externa? Now, I would say for the vast majority of people, I would say no. There's no role for oral antibiotics in otitis externa. There's exceptions to that. That's where the infection is spread to the pinna, so the outside of the ear is potentially you would give oral antibiotics. There's also a condition called necrotizing or malignant otitis externa. So that's a potentially fatal condition caused by Pseudomonas, and that needs systemic antibiotics. So that's a possibility as well. Is it okay if I share my screen again, Sunny? Just for a few moments? Let me do that. Okay, so I want to go to may not be able to get it. I just want to, yeah. So this is a global OHNS initiative that I mentioned, and they've published global ENT guidelines. And so if you just do an internet search for global OHNS, you'll find it easily. And one of the guidelines is otitis externa. And you can see that's written by our friend May Tu Thor in Mandalay. And she's put in a very good account of otitis externa with 3 levels of care. So level 1 is community care or non-doctor. Level 2 is what most of you will be at, a medical doctor, and level 3, ENT surgeon. So it's a very nice account, acute otitis externa, with lots of nice pictures and management of the different levels. So I'm not going to go through all of this now. I'd encourage you to have a look at it at your leisure. And she mentions necrotizing otitis externa that you can see there. And that's a potentially serious infection, normally caused by Pseudomonas, but also sometimes Staph aureus. So then you would need to use systemic antibiotic. I'll stop sharing now. So let's see if there are any other particular questions. Role of azithromycin. Yeah, I think azithromycin is an excellent antibiotic to use. In fact, whenever I travel overseas, I always take azithromycin with me. You can see there's a link to global OHNS, so that's good. Okay, so any other questions? There's quite a lot to get through, so and I think we've done well for time. So, but I'm quite happy to answer any other questions if anybody has any.
There's one last one, Robin. I think it's the
Yep.
post-implantation
Okay, yeah, excellent, good. Let's have a look.
otoscopes without otoscope.
Yeah. Yeah. Okay, so there's a patient who had a tympanoplasty and came to the general practice complaining of earache and tinnitus from the day after the operation. So, one thing is that when we do a tympanoplasty, we might put a dressing in the ear. So, and there would normally be an arrangement made for that dressing to be removed. So that would be the first thing to try and find out, whether there's a dressing in the ear that needs to be removed, because it says the patient has been complaining with earache and tinnitus from the day after the operation, which to some extent would be expected, but normally that would go. So if you could examine the ear with, say, a torch, you'll be able to see where there's some packing in the ear, and it may need to be removed. If there isn't packing and there's discharge from the ear, I would probably use some eardrops, and the first line eardrops would be normally to use either ciprofloxacin or gentamicin. I'd probably use ciprofloxacin eardrops, 2 drops 3 times a day for about a week, and see if that was helpful, and then see if things settle down. So I see there's another azithromycin versus penicillin in upper respiratory tract infections. One thing with upper respiratory tract infections is that most of them resolve by themselves. So that's important. If you do need to use them, then certainly in this country, we would use either azithromycin, or we tend to use clarithromycin or amoxicillin. So that's one possibility. Either of those are possible. This is a something from Tin Mon Win. I think that may be my friend Tin Mon Win, who has worked very closely with us in the School for the Deaf in Mandalay. If it is, best wishes to you. Otomycosis in CSM patients is difficult because if you've got somebody with a perforated eardrum and a fungal ear infection, if you give them clotrimazole drops, they can be quite painful. So the best treatment is, if you're working in an ENT setting, is actually to clean it out very frequently, maybe 2-3 times a week if that's possible, and maybe use clotrimazole drops. But as I've mentioned, they can be quite painful in somebody with a perforation. So can we perform emergency removal of a foreign body in the ear in general practice? The answer is yes, but you need a good, if the foreign body is in the outer part of the ear canal, if you can see it, then it's worth trying to remove it. Maybe you can have a headlight on your head and get some decent light, and possibly use a little hook to get the foreign body out. That is possible. The problem is a lot of these cases are in children, and once you start mucking about and touching children's ears, they find it uncomfortable and will start crying, and it will be very difficult for them. So you can certainly try, but the advice I would give you is to have one go, and that's all. And then if that doesn't work, then maybe advise these patients to try and find ENT care. Now, if somebody has a foreign body in their ear, it's not usually an emergency because it's not going to do them any great harm. So it doesn't matter if it's there for a few days or even weeks before it's removed. Depends to some extent what the foreign body is. If it's associated with otitis externa, then it may be an issue, of course. Okay, so yeah, I think. Thank you, Tin Mon Wing. I hope that you are well, and I remember you visiting us in the UK, and best wishes to you.
Thank you very much, Robin. Thank you for your time, please. And it's all these many years of supporting patients in both Myanmar and Nepal. And yeah, done such excellent work. Thank you.
Well, it's very nice to see. It's very nice to see so many. I can see there's been 90 participants, so that's excellent. So I'm very pleased to see and engage with so many of you. And as I've said, our best wishes go to you all.
I think before we end, we have a small poll. Poll later, who are low level. Poll just feedback poll.
Okay, yeah.
There are anonymous, but I see our blue pill ကျွန်တော်နားလေ ENT problem တွေကတော့ဒါ DHGP မှာလည်း common ဖြစ်တယ်ဒါပေမဲ့ဒီမှာပြည်မှာလည်းပဲများသောဖြင့် GP တွေကတော့သိတော့ ENT ကိစ္စတွေကို confident တော့သိတော့မဖြစ်ဘူးအဲတော့ကိုယ့်ရဲ့စေကန်းတွေမှာ group လိုက်လို့ရင်တော့ ENT ကိုနည်းနည်း confident ဖြစ်တဲ့လူတယောက်လောက်တော့ရှားထားတယ် ENT job လုပ်ဖူးတဲ့လူတွေပေါ့ Just saying, Robin, that ENT problems are common in UK general practice, and most
Yeah.
GPs are not very confident either in managing ENT
Yeah.
problems unless you have somebody who's done a ENT job.
Yeah, I think that's absolutely right, Sonia. I think the feedback would probably be exactly the same if we did a poll of UK primary care physicians. I think it wouldn't be any different. So, particularly with the last question, I'm interested in more ENT webinars. So that's 100%. So that's good. So we're going to have another one in a few weeks' time on nose problems. And I think we'll try and get one on head and neck, so throat problems as well. I'm sure we can organise that, which would be good.
So,
I think it. I see. There's one last question.
Winkle can Pamalu Palayam, Palamdi.
Can I ask you one last question, please? Japan
Yes.
CG, why do you use in Myanmar and its integral is the disadvantage? So, the hydrogen peroxide, Japan is how you recommend to the use hydrogen peroxide to put into the ear canal?
Oh, hydrogen peroxide. Yes. Well, it
Yes.
can be used in wax, but you wouldn't use it in a presence of a perforated eardrum because it could potentially cause damage to the ear. But to soften wax, that's all right.
So Jesu are, webinar Dimawe, Yalai Parome, Gulu Chin baby day out where GP or ENT Siawani or Alan Jesu Timare. Now April Laja, ENT rhinology, Itema Ted our me. GP Mashi, GP CRO. The sevens are a topic of pure dava, epistaxis to nasal obstruction or diary to know by low amylase. Okay. Hello, Jerry Timare. Thank you.